All right, this is part two of CRS, and we are only doing the cardio questions. I'm doing the IEA question bank. Two announcements. First of all, let me set my clock. Two announcements. Number one, please like the video, go to the channel, subscribe, and under playlists, you can see videos like this being made for all the other question banks for different modules and different terms, right? The announcement number two is that in the description, I'm going to put an email. You can use that as a way of communicating with me, sending me ideas, maybe sending me corrections, stuff like that. Okay, let's get started. I want to get, where are we? Okay, I want to get a solid chunk done. So I was talking about schistocytes and how they're produced. And one case that can lead to that is hemolytic uremic syndrome, HUS. And that's literally the case I was describing, that a bacteria's toxin like causes injury to the vessels, and then we get platelets, right? The other thing is TTP, thrombocytemic thrombotic purpura, right? That also, this one is because of a problem with a protein called Adam 13. And so this guy has a problem. So for it's involving VW factor processing, and the vessels just have higher affinity for platelets. They activate platelets better, platelets aggregates, and they cut cells in half, right? So basically, both of these, hemolytic uremic syndrome has a more tendency to give like kidney symptoms. TTP will give more neurological symptoms, and what you can support both of them is thrombocytopenia, right? Because all the platelets are getting overused. Now, this was a hard question. Only 30% got it, but to me, it's a really, 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 really obvious question. Okay, like I don't understand why anyone would choose eosinophilia. Like, do you think a parasite is called like doing all this to the patient? That's just crazy. That only 30% of people know what's going on in this vignette. Okay. Next question sounds to be a cardio question. Got a 46-year-old guy, has fever, fatigue, chills. Okay, past 2 days. Hypertension, fever again. Oh, he's had aortic valve replacement. Okay. Blood pressure is normal. Non-tender, some lesions on his palms. Okay, so this is like endocarditis, right? So two things like made me think of endocarditis. First of all, you get like all your fever, like this guy's sick. Okay, that's one symptom, right? One set of symptoms. This guy has a valve replacement. Okay, that puts you at risk uh, for endocarditis. The second one is like these lesions that if they're non-tender, let me think what they're called. They're the Janeway lesions, right? The tender ones are osler nodes. These are Janeway lesions. And this guy, oh, got splinter hemorrhages. Uh, what is a major risk factor for the most likely diagnosis? Exposure to animal feces, post past valvular disease. Yeah, I tend to choose this one. Yeah, because so this guy, so staph epidermis. If you have a transplant, you have, which as this guy does, right? You have an increased chance of getting a staph epidermis infection. Okay. Also, you can still get a staph aureus. Uh, so and it's aortic valve, right? So the IV drugs doesn't apply because the IV drugs, these guys, all the IV stuff goes through the right side of the heart and then hits the lung, right? So none of the IV stuff makes sense in this case because the IV stuff makes sense when you're talking about injecting stuff into your veins because they from the veins it can go straight into your right heart, but from the right heart they go to the lung, and they when they come back from the lung, chances are if there was a lot of bacteria they already stayed at the lung, right? the lung cleared them out. Kind of like what happens in uh, what's it called? Uh, Carcinoid syndrome. The lung clears out the serotonin. 44-year-old female, uh, fever, night sweats, chest pain for the past week, visible rash on her face, both cheeks. Okay, whatever. Oh, so it's kind of lupus, joint pain, more lupus. Uh, visited dentist 2 months ago, and now has uh, and you see vegetations. Okay, basically when you have lupus, you have this thing, right? Liebman sac endocarditis. It is it basically is like fibrin based, right? It's because in lupus you're hypercoagulable because of something known as antiphospholipid syndrome that happens with lupus. And so yeah, you get endocarditis, and it's usually non-bacterial. But this girl went to a dentist 2 months ago, and you know that your strep viridin family. These guys are low virulence, so they do can give you endocarditis. But if you have a damaged heart, and Liebman Sachs, which is lupus is endocarditis, can give you that um, predisposition, right? So some people want for infective endocarditis. I just think in the context of the question, the patient have has lupus. It's more like infective. So now it's a little tricky because the patient did go to the dentist, and so what you might think is that the person has Liebman Sachs endocarditis already, and then they get go to the dentist that releases some strep viridin into their bloodstream, and then the strep viridin might go into their already pre-existing uh, endocarditis and make it infective endocarditis. But if we had that, we'd have fever and stuff like that, splinter hemorrhages, stuff like there would just be a total different clinical presentation. So this time we have a 17-year-old. Not sure if it's a heart problem or kidney problem. We're going to attempt it anyways. Um, this guy this is a heart problem. Just drops after exercising, um, and dies just like that. Life is so meaningless. Um, he's like healthy otherwise. Uh, so this kind of talking about the hypertrophic. I shouldn't really write these, but he's talking about the hypertrophic heart problems, right? And they're all autosomal dominant. It's just you gotta something you yeah, they're all autosomal dominant. Um, so this time we have a 14-year-old who feels tired all the time and can't do hard tasks. Oh, so this patient has positive history for endomyocardial fibrosis. Ooh. But he has preserved ejection fraction. What do you see in this patient's heart? Okay, I like this. I like this question. You don't see dilated ventricles. Dilated ventricles are usually associated with the opposite of preserved ejection fraction because when you dilate something, you're reducing the thickness of the muscle works worse, so it can't pump out as much. Uh, BCs define areas of, so you can't see. This is a hard question because it's talking about such a rare condition, which is like this. endomyocardial fibrosis, like juvenile endomyocardial fibrosis. Shrunken ventricles could be very possible, right? And I think it's not myxoid degeneration of myocardium. Myxoid is happens with connective tissue, so and happens in something like Marfan, Ehlers-Danlos, stuff like that. So myocardium and myxoid don't go well together. Um, so define areas of interstitial fibrosis and shrunken. I'm gonna go with shrunken ventricles, but it might as well be any of the other ones, honestly. Yeah, dilated atria. So the idea behind this, I can explain why the examiner chose the answer to be C. The idea behind this is that the ventricles aren't pumping stuff out, so you have stuff um, getting stuck in the atria, right? You have stuff backflowing in the atria and increasing the volume. But as I said, I can see B or E also be correct. So this is a rare condition. Okay, 82-year-old. Just read that as this is bottom hole. Interesting way of saying it. Okay, 82-year-old comes to the ER, unconscious in the park, and then just gain consciousness. So that on itself makes me think of an arrhythmia, but that's just one of the things it could be. Uh, yeah, severe chest pain, period of fainting. Okay, maybe it's an MI. Mm. He was speed walking too. He has had prior episode of syncope and chest pain, and then plus shortness of breath. Okay, you got murmur at the right sternal border. Right sternal border between the second and third intercostal spaces. That is where the aortic valves hearing. So if this is your sternum, right, this is top of the sternum, this is the bottom of the sternum. So the aortic valve is here, pulmonic valve is here, tricuspid valve is here, and mitral valve is here. Right, this is the patient's left, this is the patient's right. So this is describing this area, aortic valve. So what would an old guy have problems with his aortic valve? If he's as old as he is, it's probably because of a calcification problem. Um, right now, that's one thing actually. I don't know for sure. Let's go through the choices. But it's for sure not maximatus degeneration because that happens in Marfan syndrome. And if you're 82 by now, you know if you have Marfan syndrome or not. I think we're more likely thinking about a degenerative process. The fish, this we think of the chronic phase of of rheumatic fever, right? The chronic heart disease associated with rheumatic fever. Sterile vegetations with fibrin, we think of hypercoagulability. Now, that can be in case of adenocarcinomas. That can also be in case of lupus. So now we have two things: dystrophic calcification and fusion of leaflets due to fibrosis. So one thing I remember is that fusion of leaflets happens with inflammation. Fusion is with inflammation, and inflammation is like when you have like the case of the heart problem, right? The rheumatic fever, okay? But old age does not necessarily happen because of inflammation. It happens because of just overworking, right? So you just get the calcification part. Nice. How much time? We're halfway through this video. Okay, let's speed it up. 34-year-old, racing heart. There's a murmur between S1 and S2. pop noise is heard and the murmur gets louder as it approaches S2. Okay, what happens between S1 and S2? Basically, S1 is when mitral, so I'm just going to draw the left ventricle. So interventricular symptom, septum, this is the septum, this is the mitral valve, and this is the aortic, right, valve. Okay, so S1 is when heart contracts really fast, this guy gets shut, that's S1. And then contracts enough to open this, it opens it, empties out, and then when this closes, when it's almost done relaxing, you hear S2. Now, when we are hearing a murmur that starts with a pop and it's between S1 and S2, it means, so like blood should be going through this, right? Should be usually normally going through this. But and it doesn't say where we hear the murmur. It just says there's a pop. The fact that there's a pop, it means like something happens that's not supposed to, and that means like blood is going down S1 that's not supposed to. Uh, so blood is going down blood is going down the aortic valve as it's supposed to, right? And then this guy gets pressured. There's pressure building up, and then one of the leaflets pops open. So instead of like connecting like this, it connects like one of them pops open like this, and then there's blood going out, and it gets louder as you approach S2. So there's more and more coming out as you get to the end of your systole. Uh, and then disappears in diastole, right? Because this thing is going to open up. Uh, so now this pop is mitral prolapse. This whole thing I was describing is mitral prolapse. Okay, and one thing that's associated with is that these these like valves, they kind of like balloon out. So if that's normal, they balloon out like this, right? That's also the prolapse part. And this happens in Marfan syndrome, people with connective disorder problems. And you get so the reason, imagine this is connective tissue, instead of like it being tight and like binding hard, it's kind of like floppy and like goes deeper, right? That's like the reason that happens is because of these myxomatous degeneration of the aortic valve. It basically means it's a certain descriptive. So myxomatous is like by adding gags, right? Glycosaminoglycans, right? So it's basically what it means is that the actual like connective tissue that's supposed to be tough is getting replaced by not so tough connective tissue, and it's just getting degenerated. And it's actually not the aortic valve. What am I doing? Of the mitral valve, right? Um, so that's what it means. It happens in something like Marfan syndrome. And also, the other side of this coin is that it's not the only thing happening with this patient. With some of the other patients, the aorta gets dilated, right? Aorta gets dilated. Same type of pathology, myxoid or myxomatous pathology. When the aorta gets dilated, so imagine this is the aortic valve. It's like this. If this is get if gets this gets dilated, then it kind of looks like this, so they don't touch properly, and then the blood is going to be regurgitating back. So these guys will also get aortic regurgitation. But the mitral prolapse is a more common cause of death and cardiac failure in people with Marfan syndrome. So the next question is talking about, I think it's a cardiac question. Is a male newborn? Yeah, it's a cardiac question. Um, Aorta is branching from the right ventricle, and there is a ventricle septal wall defect. Okay. Hmm. I'll tell you what it's not. So it's asking like what does the mother have? RH incompatibility can lead to a lot of problems, but it's none of it is like embryological, like structural like this, right? The big problem with RH incompatibility is that the mom has antibodies against the kids, the babies, um, RBCs basically. Okay, it starts destroying the RBCs, but it doesn't cause like a valve being plugged into the wrong place. Gestational diabetes is really tempting. Fetal alcohol syndrome is tempting. It's not Turner syndrome. Turner syndrome causes coarctation. Down syndrome can cause a bunch of stuff, but um, I don't think it causes this. Between all these, I'm going with D, but I don't really know. It's D. So yeah, this is the way I think about it. Down and fetal alcohol syndrome, they cause a lot of septal defects because these, like, the problem here is basically like neurocrest migrations problems, right? So that you don't you the cells that are supposed to close the septa, they don't work properly. I know gestational diabetes, I just know it just gives rise to this like weird looking, um just like completely out of order, uh completely out of order placement of aura that's branching from the right ventricle. Okay, kind of one of those things you gotta know, gotta put it into memory. But as you can see, again, the reason no one chose this is because no one knows what this is yet in CPR or CRS, but no one had a clue what this was. So don't feel too bad about not knowing it, but also write it down somewhere so you do remember it for an exam. 43-year-old comes to the ER, fatigue palpitations, anxiety. She has had similar symptoms before. Oh, and when she was a kid, she had a sore throat. Uh, she had connective tissue that she can exercise. So there is a mid-systolic click. This is a mitral prolapse, mid-systolic click. This is the same thing here, right? Same thing here. This valve clicks out at some point during systole, and the reason is because the connective tissue isn't working that well. So asking what's a common complication. Hmm. Is it myocardial infarcts? No. Aortic stenosis? No. I said Marfan's can cause dilation, but not stenosis. Restricted cardiomyopathy. It's not restricted necessarily. I think it's dilated cardiomyopathy, and so do a lot of people. But it thinks ventricular arrhythmias. Okay, so I don't exactly know what the examiner thinks, but I can explain to you what happens. So remember that we said, uh, maybe if this was just arrhythmias, I would go for it, and I'll explain to you why. So you got your ventricle, right? It's beating every time it beats back into the atria, right? And so there's volume saturation in the atria. So atria, after a while, atria gets hypertrophied, and so you get atria. It gets bigger, and when it gets bigger, it has an increased chance for uh, atrial fibrillation. Okay, that's what came to my mind initially. But the fact that it says ventricular arrhythmias, I don't know about that. But again, you're getting a hypertrophy of the heart muscle because it keeps pumping stuff out, and they keep leaking back in. So it's getting hypertrophied, and whenever you have like a big hypertrophied heart, you have an increased chance for MIs, you have an increased chance for arrhythmias, all that stuff. But I would go with atrial arrhythmias. Okay, so this time you got a 9-year old, low set ears, short stature. I don't know what this thing means, but it's probably echocardiogram shows a congenital deformity. Uh, and so the answer is D. Sorry, E. So this is coarctation of the aorta that happens in Turner syndrome. So you got your aorta, it's coming off your heart, right? I'm just going to draw it as one line and it goes down, and this is your heart, right? Coarctation happens somewhere along here. It gets tighter here, right? So what ends up happening is that aorta, there's vessels coming off it even here, right? And there's the three big ones here. This is the three big ones, but there's still like smaller ones. So when you have the coarctation happening, these vessels will, and so there's also vessels underneath. These are like the intercostal vessels. These vessels get small and they kind of like connect together in small connections, okay? And all these vessels, they run underneath a rib, right? Or they run in proximity to a rib. There's a rib next to all of them. I think the rib runs right under. Rib is right, right above the vessel. Okay, so I drew them right here and here, not here. So when there's coarctation here, there's a pressure differential between like up and top and bottom. So these anastomoses become important. So blood is gonna go. A lot of blood is gonna be coming from these vessels. So these vessels become more and more prominent. So rib notching basically means when these vessels become more prominent, you see the vessels, the arteries path onto the rib because it's way bigger than it's supposed to be. It eats into the rib. So you get these notches onto the ribs. That's what rib notching means. What it happens, see this girl is 9, it wouldn't happen in like a kid that's just born. This is like a process that happens through years. This is a kidney question. No, not a kidney question. Oh, I just saw beta platelet sheets. All right, this is amyloidosis question. Most likely, here, complaining of edema in both feet. Most likely a and then we got irregular pulse. So we got AFib. What else can we get? We could get restricted cardiomyopathy, because these things will get into your heart, increase the characteristics of your heart, whether it's like how big it is, how easy it can relax, and how easily it can contract. All right, this video is almost finishing too, so I'm gonna end it here.